Good morning. So first, I'd like to thank meeting organizer for giving me this opportunity to share with you our recent progress in developing a protein replacement therapy for dystrophic EB. Our approach is very different from what you heard in the last 2 days, bone marrow stem cell transplantation. So a brief introduction, so I guess you heard a lot, just a highlight. So skin has 2 layers, epidermal and dermal, that are held together by structure called enzyme fibers. So enzyme fibers are made of type 7 collagen, and mutation in gene in type 7 collagen result in DEB and absence of normal enzyme fibers. DEB can be inherited either as dormant DDEB or recessive RDEB, in which recessive RDEB is most severe. And this patient have a severe skin fragility, trauma-prone blister, erosion, scar, media, cyst, nail dystrophy, esophageal strictures, and dental abnormality, which you heard in the last 2 days. So what's the type 7 collagen? Type 7 collagen is a major component of enzyme fiber. It's shown here. Attachment structure in the basal membrane zone that anchor epidermal and dermal layer together. So under electron microscopy, enzyme fiber are weak stack-like structure, which is shown here, provide dermal-epidermal adherence. So for the last 15 years, our lab have developed various therapeutic approaches, including the ex vivo and in vivo gene therapy approach for DEB. So we saw the feasibility, use 2 preclinical animal models. We saw the feasibility of direct intradermal injection of gene-correct RDB fibroblasts, so-called cell therapy, and lentivirus vector-expressed C7 vector therapy, or recombinant type 7 called itself protein therapy for potential treatment of DEB. So today, I will focus on protein therapy, which is the first therapy we are going to test on human patients. So why? Because we can make a lot of recombinant human type 7 collagen. We show that the recombinant type 7 collagen is like authentic type 7 collagen purified from skin cell, both structurally and functionally. And we can deliver type 7 collagen to DEB patients with intradermal injection, intravenous injection, or topical application. So additional advantage of protein therapy, no virus or living cell involved, which we heard a lot of bone marrow stem cell transplantation, you need to use a virus vector to infect cell to correct those IP cells. And the dermatology have been injected collagen 1 every day in clinic for wrinkle improvement. So this practice has been done routinely in the dermatology clinic. And collagen are generally immunologically inert. Collagens are stable, persistent, which I'll show you data later. And technology is completely and easier FDA hurdle and approval. So first, most critical element to do the protein therapy is be able to get a large amount of protein for injection. So using the molecular biology approach, we have molecular engineered a human RDB fibroblast to overexpress the type 7 collagen. Compare this with the gene correct cell with parent RDB cell, you see a huge amount of type 7 collagen here. And we can purify large quantity of recombinant type 7 collagen from this gene correct cell by 3 simple steps. Note last Q several steps result pure type 7 collagen product. So we normally apply between 2 to 5 milligrams of recombinant type 7 collagen from 1 liter culture medium, and show that the recombinant type 7 collagen is behave identical to authentic type 7 collagen in the human skin, both structurally and functionally. So our animal model is in vivo xenograft transplantation model. So what you did, first you put a piece of RDB skin onto the back of anemic noodle mice, then we intradermal inject this type 7 collagen into this graft. So at the very time after injection, biopsy was obtained from this skin graft and subject to immunostaining and immuno-EM using antibodies specific to human type 7 collagen. That's injected protein. So note in this slide, without protein therapy, RDB skin shows the dermal-abdominal separation and has no type 7 collagen expression at the basal membrane zone. where protein injected skin has a good dermal adherence and strong type 7 collagen expression at the base membrane zone. Furthermore, a single intradermal injection provides stable incorporation of type 7 collagen at the base membrane zone for up to 8 weeks. So this indicates how often you need to do protein injection, so maybe once every 2 months. So not only is type 7 collagen restored at the base membrane zone, it also forms into anchoring fiber structure, which is the most important structure you need to restore. So note, I injected DB skin, there's no anchoring fiber, where injected DB skin has an abundant human anchoring fiber at the base membrane zone, demonstrating a correction of this structural disease abnormality. So our second animal model is type 7 collagen knockout mouse model that was generated by Dr. Uito's lab from Philadelphia. So at 1 day after birth, this mouse has a big hemorrhagic bruise on the paw, and as well as a ventral side animal. So histology showed a dermal separation, and immunostaining revealed a complete absence of type 7 collagen at the base membrane zone. So without treatment, this mice normally die within a few days. So in this experiment, we injected type 7 collagen into the back of the mice for 2 days. Note, new blister formation stopped and the mice continue to live. So we then took a skin biopsy at the very time after injection and subjected to analyze for human protein incorporation. Note, injected protein was detected as early as 6 hours after initial injection and sustained up to 28 weeks with weekly continued injection. Our study further showed that C7 have a half-life of at least 2 months in vivo, which is consistent with those DB skin transplantation model. So also C7 only went to skin or not to any other organs. Again, this protein injection restored the anchoring fiber structure in this DB mouse model. So as I mentioned before, without treatment, this DB mice normally die within a few days. So this Kaplan-Meier survival curve shows that the protein injection significantly increased the survival of these DB mice. So median overall survival was 5 weeks for 45 treated mice, compared with 1 week for 30 uninjected DB or untreated mice. So next, we want to evaluate our protein therapy in a large animal model, that's a DB dog. So this DB dog is a strain of golden retriever that was initially identified by Dr. Miniguchi from France. So in collaboration with Dr. Pin from France, we use this model to test our protein therapy. So this dog model RDB duplicated RDB phenotype in human. So please note, there's also note there is ulceration. Note there is ulceration also in the hard palate, inside the ear, also in the esophageal. So ulcerated or trophic scar of the foot. So this the active skin blister normally stop at the age of 8 months. However, formation of blister erosion in the upper digestive tract, include oral mucosa and esophageal, persistent for lifetime. So these mice usually have a poor feeding and result in a growth retardation, which is shown on this side. So note that this is affected DB dog compared with a wild type little mate. So mutation analysis identify a missense mutation in the middle triple helical domain, and this mutation result in the production of wild type 7 mutate type 7 collagen expressed at a significant lower level compared with normal dog skin, which you show here. So histology showed a dermal separation, and EM showed a complete absence of recognizable anchoring fiber in the dog skin. So to test protein impulse therapy in this model, the most important thing is that need to identify antibody only recognize injected human protein and did not react with endogenous mouse dog mutate protein. So shown in this slide, we identify only antibody only recognize the C7 from normal human skin, but not from either normal or to affected DB dog skin. So this antibody is used for us to differentiate between injected human protein and endogenous dog protein. So in this experiment, we injected about recombinant type 7 collagen on the lip and ear of 2 dogs at one side. Another side we inject with PBS as our control. Note, injected human protein was readily incorporated into the dog-based memory zone in both dogs, whereas control PBS injected site has no standing at all for human type 7 collagen. So we found that one ID injection provided C7 at a level of 40 or 60% of normal human skin. So it has been known that only 30 to 50% of C7 needed to be restored for good dermal adherence. So one injection is sufficient to provide sufficient protein to have anchored dermal together. So what about the phenotypic improvement? Note there's a lesion which is in the lip or the mouth in this dog. So after 28 days after injection, this lesion was healed. So additionally, look at this C7 injected dog also have a reduced inflammation, reduced erythema, and no new erosion developed after 28 days after injection in the ear compared with the uninjected site. So based on success in the intradermal injection in 3 preclinical animal models, our USC lab has initiated NIH phase 1 human trial with this protein therapy finding by NIH grant. So this slide summarizes our progress on that screen or clinical trial. We have screened 25 patients and identified 18 patients who meet our criteria for protein injection. For all these patients, we have performed lab tests and clinical evaluation. This includes IF staining or skin biopsy for baseline C7 expression and EM for enquin fiber formation. The patient's genotype was performed and ELISA analysis was conducted for anti-C7 antibody. So we also established that human keratinocyte and fibroblast culture from this skin biopsy for evaluation of C7 expression and cellular biology. All these patients, we have performed medical history and renewal of the system. So this is a very complicated slide which summarizes all our actual data. So including the C7 expression at the base memory zone and EM analysis of enquin fiber structure and assess of antibody by immunofluorescence as well as ELISA and the mutational analysis genotyping. So out of these 24 patients, we have identified 18 patients that will meet our criteria. It's most interesting, 3 of these 18 patients actually have the same mutation as you see in the dog. So I guess they will have if you see the result from dog, this patient will have a benefit or improvement. So to summarize this part of intradermal approach, we show that intradermal injection of C7 restore both C7 and enquin fiber at the base memory zone of RDB mice. We also show that RDB clinical phenotype reverse and survival dramatically increased. In addition, we show intradermally injected human C7 readily incorporate into the base memory zone RDB dogs and ameliorate their disease phenotype. We complete the screen phase of our study and identify 20 patients who meet our study criteria. So production of GMP-grade human C7 will be finished by September, and we'll begin ID C7 injection, so that second phase of our clinical trial early next year. So now I want to switch my gear to second part of our talk to show you our recent unpublished data demonstrating the intravenous injection approach for DEB using 4 preclinical animal models. So intradermal injection therapy are limited by a small diffusion rate of intradermal inject cell, protein, and antivirus vector. Some sites inaccessible, such as esophagus, and patients with extensive boosting will require many injections at many sites. So a therapy that has potential for treating all all of the RDB patient wound site at the same time would be highly advantageous than over local treatment. So to obviate this problem, we envision delivering C7 simultaneously to multiple sites and in a separate site by intravenous injection of recombinant protein. So we asked 3 questions. Would this IV inject C7 get to the wound and incorporate into the base memory zone? Would inject C7 go to other organ? So this is important. We need to demonstrate the safety. Would this agent promote the wound healing? So first animal model we use is a normal mouse model. So what do? We make a wound in the back of the mice. Then we intravenously inject recombinant type 7 called through tailwind into the mice. So at the very time after injection, we biopsy the skin and subject analysis for human protein expression. So showing in this slide, we found that the injected human protein specifically home to wounded site in this mouse, not in unwounded site. Furthermore, when IV injection was performed with increased concentration of type 7 collagen, there's dose-dependent increase in the incorporation of human protein at the base memory zone. So we also took multiple organs subject to immunostain to ask, is this protein also go to any other organ? So showing in this slide, injected human protein only went to the skin, but not in any other organ, including the liver and lungs. So surprisingly, we consistently notice that the mice wound receive IVC7 demonstrate a accelerated wound healing rate compared with the mouse wound that receive PBS injection, our control. So as shown in here, you can see the wound area by C7 injected wound area have a much smaller wound area compared with the PBS injected wound. So this data demonstrate the previous unrecognized potential use of type 7 collagen for promote wound healing. So our second animal model is a guava DB skin model. So in this experiment, we first got a piece of RDB skin for knockout mice and to the back of asthmatic noodle mice. At the 2 weeks after graft, we took a skin biopsy and subject analysis. Know that there's no human type 7, there's no type 7 cause expression at the base memory zone, and there's dermal-abdominal separation. So this data demonstrate graft knockout C7 DB skin retain RDB phenotype. So then we perform IV injection recombinant protein in this skin graft. So note that injected human protein was only detected in graft DB skin, either wounded or unwounded, no matter you can make a wound or not. In contrast, the DB skin graft received either PBS injection or without any injection. There's no human protein expression at the base memory zone. Also, there's a dermal-abdominal separation. So from this data, we conclude that although the characteristic of RDB wound is superficial, its subclinical wound is sufficient to allow intravenously injected recombinant C7 to home to it, incorporate into the dermal-abdominal junction, and improve the abdominal-dermal adherence. So not only is type 7 collagen restored, you also see the restoration of ganglion fiber at the base memory zone. In contrast, the PBS injected DB skin has absence no type 7 no ganglion fiber at the base memory zone. So our third animal model is a hypertrophic mouse model that was developed by Dr. Lina Tudemann's lab from Germany. So this model actually, this model duplicates severe RDB. So this includes boosting within 24 hours after birth, and there's a dermal-abdominal separation here compared with normal mouse skin. And there's actually this mouse only expresses 10% of normal type 7 collagen in their base memory zone. So it's different than Urito's mouse model. It's completely knockout. That means they don't express type 7 collagen at all. Also, there's a growth retardation in this RDB mice as a result of malnutrition because they have erosion and blister in the upper digestive tract, including oral mucosa. So another very unique feature of this mouse model, they also have a mutant deformity in the extremity of this mice, when showing here when you compare with this is the human and this is this mouse, which also have a mutant deformity. So this is a very unique feature we can assess. So in collaboration with the Dr. Lina group in Germany, the postdoc fellow in her lab injected recombinant type 7 core in this mouse model. So at the very time after injection, they took a section from different area and subjected immunostaining with the antibody only recognized injected human protein. So note that human protein was detected at the skin, in the tongue, as well as the esophageal. With all this site is not accessible by intradermal injection. So how about phenotypic improvement? So note, as I mentioned before, the mutant deformity in extremity of this mice is a hallmark of this disease with a very close mimic a human situation. Note the C7 injected mice have experienced less nail loss with 3 and 3.5 digits, compared with uninjected mice which have 2 digits left at the same time. Additionally, the anal blister was significantly reduced in the C7 treated mice compared with untreated mice. Because this lighting, so a lot of these images is not very easy to appreciate. So lastly, we also test our IV approach in large animal model as a DB dog, because this is we need to make sure this is safe for IV injection. So dog receive a single IV injection into self-fed vein or forearm. So injection was done without any anesthesia. So we did not detect any adverse effects seen in either dog. So no change in breathing or behavior during the IV infusion recombinant C7. And this procedure is only finished in 10 minutes. So we took a biopsy from different sides of the dog and subjected immunostaining to see whether any of these human protein go and incorporate in their basal memory zone. So note, the human protein was detected in the ear, lip, and also in the back at the very time after injection and sustained up to 9 weeks. So this is consistent with the intradermal approach. I show you that the protein have a half-life of 2 months when you do an intradermal injection. Most interestingly, some site is unwounded. We also see the human protein expression at the basal memory zone. So additionally, there's a good dermal-abdominal adherence in the section obtained from different sides of this animal after injection. So this includes the ear, nose, and lip. Additionally, we also noticed that the IV-infused dog demonstrated less erythema and blistering in heart plate after IV injection, which compared with the day 0 before IV infusion. So this slide just summarizes the distribution and durability of recombinant C7 at the basal memory zone RDB dog after IV injection. So the take-home message is that IV infused C7 were detected in the multiple organs and the wound site, include ear, lip, nose, and back, and also was detected on wounded skin in both here. Additionally, a single injection provides stable expression at the basal memory zone up to 9 weeks. So this is how often you want to do the IV injection, maybe every 8 or 9 weeks. So to conclude the second part of my talk. So we saw that IV inject C7 home to unwounded RDB skin, restore human C7 and enzyme fiber at the base memory zone, and correct dermal-abdominal separation. IV inject human C7 stably incorporate into the base memory zone on RDB dog for 9 weeks after a single intravenous injection or intradermal injection. IVC7 home to multiple sites of hypomorphic RDP mice and correct disease features that include meeting deformity or reduce the disease feature. And IV inject human C7 did not home to other organs. IVC7 have no adverse effect in RDP dog, RDP, or normal mouse. Dog data show the safety and efficacy of IV recombinant C7 in a large animal model. ID and IVC7 enhance skin wound closure in vivo. So in the interest of time, I don't have time to show you. Our recent data also demonstrate topical application of C7 also restore C7, reverse RDP phenotype, and enhance wound healing. So implication from this study, delivery of intravenous C7 into RDP patient has a potential treating all of patient lesions simultaneously, include skin, mucosa, and esophageal at the same time. The ability of IV inject C7 to home and incorporate into unwounded RDP skin suggests that IVC7 could prophylactically prevent new blister and erosions. So lastly, I would like to another people in our laboratory, as well as our collaborator, including Dr. Didier Penn from Lyon, who provided RDP dog, Lina Tuderman from Faber in Germany, provided hypophobic DB mouse model, and Yoli Uito from Philadelphia provided us with type 7 culture knockout mouse model, as well as Dr. King from Oregon, who performed all the EM work. So this is really international collaboration teamwork. And also I would like to support our acknowledge our grant support from NIH, from Local Tissue Repair, the Dermatology Foundation, EB Medical Research Foundation, Jackson Gabriel Civil Foundation, Video Foundation. Also lastly, I really like to thank the patients who involved in our clinical trial. Thank you for your attention.